My name is Michael Manz. I'm a hepatologist at the Medical School of Hanover, Germany. It is my pleasure to introduce today to you a new publication to be published in Gastroenterology entitled Budesonide Induces Remission More Effectively than Prednisone in a Controlled Trial of Patients with Autoimmune Hepatitis. Autoimmune hepatitis is a disease where loss of tolerance against the patient's own liver is regarded as the primary pathogenic process. This disease has first been described by Waldenström from Sweden in 1951, and later Dr. Kunkel in the United States has confirmed his observation and extended the investigations in autoimmune hepatitis, showing that immunosuppressive therapy is able to induce remission and to prevent progression. Autoimmune hepatitis is treated for decades now with immunosuppressive regimen, either steroids alone or in combination with azathioprine. The studies that we base our guidelines on were published in the 70s and 80s, meaning years before the discovery of the hepatitis C virus. Therefore, in previous studies on the therapy of autoimmune hepatitis C virus infection could not be excluded. In this prospective study, which is the largest prospective study ever in the treatment of autoimmune hepatitis, we compared the topical steroid budesonide with azathioprine versus prednisone in combination with azathioprine. This study had a phase A for the first 6 months, when the primary endpoint of treatment was complete remission, meaning normalization of transaminases, AST, ALT, plus lack of predefined steroid-specific side effects. In a second phase of the study, patients that were previously treated with prednisone were switched to open-label budesonide in order to investigate whether the switch after 6 months from prednisone to budesonide led to a reduction in steroid-specific side effects. The dose for budesonide was 3 times 3 milligrams per day initially versus prednisone 40 milligrams per day, each in combination with 1 to 2 milligrams of azathioprine per kilogram body weight. The results were as follows. The complete remission was achieved in the budesonide arm for 47% of patients versus 18% of patients with prednisone plus azathioprine, meaning normalization of transaminases plus lack of steroid-specific side effects. When we look just at biochemical remission, it was 60% normalization of transaminases for the budesonide arm versus 39% for the prednisone arm. This definition of normal transaminases is also part of the new 2010 AASLD practice guidelines on autoimmune hepatitis and differs from the less than 2 times upper limit of normal as definition for remission in previous guidelines. What is also important to note is 72% of patients in the budesonide arm did not have steroid-specific side effects versus 47% in the prednisone arm. When we now look at the second part of the study between month 6 and month 12, we found that after 6 months, 45% of patients in the prednisone arm had steroid-specific side effects. When we switched these patients from prednisone to budesonide, this figure dropped to 26%, meaning that the change from prednisone to budesonide in this prospective investigation led to a reduction of steroid-specific side effects. So in summary, budesonide, the topical steroid, is able in non-cirrhotic patients to induce remission more efficiently than prednisone, each in combination with azathioprine, and at the same time there were less steroid-specific side effects with this topical steroid compared to prednisone. Finally, when we switch from prednisone to budesonide, the number of steroid-specific side effects was reduced between month 6 and month 12. It's important to note that in this study, non-cirrhotic patients were included because in cirrhotic patients, the topical benefits of budesonide, meaning the 90% first pass effect and therefore less steroid-specific side effects, is lost due to portal hypertension. I thank you very much for your attention.